And now we would like to invite our first keynote speaker, Dr. David Bell, to give his talk titled Data-Driven Simulation for Healthcare Innovation. Dr. David, please.
Okay, I'll get started. Thank you very much for my invite here today. I'm going to talk a little bit about my discipline, which is computing, but I've also kept it very open. And I think a lot of the topics I'll be talking about touch on some of the previous speakers about research collaboration and also how you bring in industry, because a lot of UK funding of research requires you to fetch in collaborators to participate in some of that research. Before I get started, I'll give you a little bit of an intro to myself. I think I'll hold this. I'm a senior lecturer in the Department of Computer Science. At Brunel University, you're part of a department, but you're also a member of a research institute. And the institute I'm a member of is the Institute of Environment, Health and Societies. Part of my research, some of it I'll talk about today, onto a startup company called Ahliauniversitybh, and I'm the founder and Chief Technology Officer of that company. My research areas are modeling and simulation. I look at health, but I also look at user experience, and I also look at cybersecurity. So some of the topics I talk about, I've applied in some of these different areas. So today I'm talking about healthcare, but I've also applied recently in a paper the same techniques, but in migration planning in disaster relief areas in Africa. We just got a paper published in Nature Scientific Reports. I teach digital service design, social media analytics, and cybersecurity around blockchain. And just a little bit of my background, prior to coming to university to do a PhD and teach, I was a director at Deutsche Bank in their emerging markets technology department, so building trading and risk department systems. Okay, Brunel University, London. I'll give you a little bit of an intro. It's in, if you know London, it's pretty close to Heathrow Airport. It's about 50 years old, or just over 50 years old. About 50 years ago, that picture is probably early, about 50 years ago, when that's our lecturing centre, but an early Stanley Kubrick movie used that as a prison. And I think some of our students sometimes think it might be a prison. But now it's modernised like all our establishments. This is our new computer science department. We've just moved in about 9 months ago. But it's quite an interesting sort of new building. I think one of the interesting parts about it, it's one of these modern sensor-driven buildings, and we've included some of our students in research projects around controlling the building. I'm not going to go through all of this because I think I'll get the red card before I get through my slides, but I'm part of the modeling and simulation group at Brunel. I think this slide just says we do quite a lot of research around simulation in engineering, health, across Europe, and also use it quite widely in education. But today I wanted to give a few perspectives. I wanted to talk about data in simulation, and particularly big data in simulation. You know, simulation has got a long history of using data, so this is nothing new. The perspective I'm going to talk about is a little bit about how we use data. I'm also going to talk about how some of the techniques that we've researched at Brunel, we've taken forward and applied it in a healthcare setting to test out strategic change. So we're all used to new strategies coming out of organizations, and often strategies come from some gut instincts, some past experience, what happened recently. And the health service is the same. And what we wanted to do in this research project was, rather than just reflect on their strategic change and follow it, we wanted to test out some of the strategic changes before they took place, so we could start to rate some of those changes. I'm going to talk a little bit about multidisciplinary projects, which this was one, and then sort of synthesize it a bit at the end. So, in management literature, you will get lots of talk of strategy. This, I'm talking about strategy in terms of testing your strategy using simulation. And I think part of my talk will cover the important kickoff and articulating the problem area. Another quite key area is team formation. You know, who are we going to bring in for our collaboration? And interestingly here, you know, this was a research project with Brunel as participants. It had two commercial organizations who were simulation companies who were providing some of the technologies, and we had the National Health Service who had their strategies. So we had 4 teams in this group. And then we went on, our next phase is around how do we understand this organization? You know, if anybody has been to the UK or knows a little bit about the National Health Service, I think it's the largest company in the UK, if not the world. You know, it's a generic health system for everybody in the UK. So it has, you know, it's 60 million customers, and it's quite a complex organization. And we had to understand, where do we get data? This is the foraging. How do we gather it? And in some cases, how do we farm data? And this is where I'll talk about how you use simulation to give you data that you don't have already. So a good example is a future state. If you're building several new hospitals and you've got a demographic, how do you build data for that future state? I'll talk a little bit about data and evidence management and then some of the analysis. I'm going to fly through this. This slide is a mixture of showing my age and also how computing's changed. So when I started in computing as a 12-year-old, I had that weird black box with 16K of RAM, and I used to start programming when I got my interest in computing. And now when I look at my children who are going through towards the end of their teenage years, they're not playing with this little black box. They're looking at the world. They've got this lens on the world. So computing's changed a little bit in that generation. When I started work in banking, we put in regional data centers in Tokyo, New York, and London, and we thought we were being quite progressive. Whereas now, Amazon give me the same amount of cloud space as an academic for free. I can just deploy it within about 30 minutes, which would have taken me 6 months to put together 20 years ago. And I think a lot of what problem articulation is about is saying what next for that organization. So it isn't just about process or technology improvement, it's about what is this future world going to look like. I also talked a bit about data. Data is everywhere in organizations now. We're adding more data as we go along with the devices we carry, with new sensors. We often see small data, you know, the summaries, the PowerPoints, the articles, but it's really understanding what is below the waterline. So what's there that we can use? Some of it's analyzable, some of it takes a little bit more work. My other sort of startup slide, so we're in a time of change. we've got lots of data, and we often see a lot of things about big data, and I like this guy's website because he looks at these data sets and looks for correlations. And the whole website's full of correlations, and I chose this one. Highly correlated data. So here, the divorce rate in Maine, he's an American guy, so it's all American type statistics. So on the east coast of the US, the number of marriages that fail in Maine is highly correlated by the consumption of margarine in the United States. So if I'm coming out with some new strategies, what would I do? Put tax on margarine to improve family life? It could be, get rid of it. So that's what the data's telling us. And this is a little bit of the problem with strategy, isn't it? Often we can see these things, and we have these hunches. They're not always right. And I think what I'd add to this is that we have to think about causality. So it's not just about, especially in our simulation world, it's easy to simulate things that aren't really true. We're searching out causality. And we're doing this because we want to run some analytics. We want to understand a little bit. We want to put some robustness into this data analysis. So we want to add, as the definition at the end, a scientific process to transforming data into insight. So it's not just correlations and things like that. What did I put this slide in for? I think this is the usual Gartner piece of research, which is really showing you what's going on in terms of IT research. And you can see a lot of what's at that peak of interest at the moment is really around data analysis. So deep learning, machine learning, these types of techniques, there's lots of interest in them at the moment. But it's how we use these types of techniques which is important. So, data. We've got it everywhere. We've got it, each of our governments. I've put the Office of National Statistics, which is the UK organization, but Bahrain will have its own office collecting data. We've got the NHS, where they collect data about every person who enters the health system and their route to leaving or coming back. We've got a semantic web, lots of data on the web, if it's semantically connected, useful. And our mobile phones, quite a large amount of data on our mobile phones or on our social media backgrounds that are in there. And we have to weigh this up. How are we going to use this data? And I'm going to tell you a little bit about, sort of give you a hint about what I'm talking about or getting to at the end of this talk. And it's really about, a lot of my research is using machine learning techniques to look at this data, but not come out with ideas or correlations. I use machine learning to build models. So we build models that we can then simulate and start to feel a little bit more comfortable. So it's machine learning to look backwards on that historic data, maybe adjusted to make it more realistic. And then simulation is looking forwards. So we haven't got the data for the future. This is when we simulate. Okay, I'm going to switch a little bit into sort of health projects. And as I said, we've done, over the last 3 or 4 years, we've carried out similar projects in health, some environment, some industry type projects with Ford and some perishable goods producers using very similar techniques to these. But I think the health service is quite an interesting one because it's quite a rich data set and the problems are very apparent in the system. The nice thing about the health system in the UK is it's heavily modeled. Not all health systems around the world are like this, but if you have any problem in the UK, there will be a flowchart of this type with embedded flowcharts, and this is what clinicians will follow in the health service. This is what has been costed out to be economically effective for people in the UK health system. And I'll talk a little bit about economically effective, because health economics is not like buying and sell, it's not a money-based thing. Health economics is a little bit more complex than that. So we have lots of interesting models, so we know what will happen to people in these hospitals. With our Office of National Statistics data, we can sort of look at future projections and work out different patient groupings and what they're going to look like. And what I do in the research is really, these have come out of a number of research projects. Some are cited there, but it's really about breaking down the types of people in these environments. We call personas, and that's the digital personhood. So what does someone look like? So we don't treat everybody like just a user or a single person. The other difficulty is often people would say, okay, well, we don't in our system. We have old people, middle-aged, young people, but that doesn't work in the health system. From our data analysis, we had people in the UK system who were in their 50s and very frail, and people who are 80 and very fit. So there's a very complex sort of list of types of people in there. We do a lot of work with clustering, finding these patient groups and patient groups in particular locations around the country. We then use some analytical techniques, decision trees, to work out some of the rules that people follow. So from the data, can we take the data, build a decision tree which mimics what NICE or that flowchart looked like? So how likely is it to follow that? Some content analysis with concept analysis. And armed with this level of analytics, we can then build our simulation models. I put agent models, but we use different simulation models as well. And we often marry our techniques together. So this is the multidisciplinary piece. So we may take the economics from an economics department or a health economics department. We may do some modeling. I've just done a simple agent model there for the picture perspective. And also, we may fetch in some systems or discrete event modeling to build some data as well. And these are hybrid techniques, which I'm sure Tilal may talk about a little bit as well. Okay, so that's sort of my interest. I was going to talk around a few of the projects that we've carried out to give a little bit of insight into how have we got to this point. So I talked at the start in my sort of summary of what I do is I started a company called Ahliauniversitybh. This started as a government-funded research project called TPOCT, working with collaborators at Warwick University and a number of simulation companies. And what this is about is really, we carry out a lot of this analytics, so I can happily go and run my algorithms, get some results, and produce a paper, and then nobody reads that paper. You know, where clinicians do trials, they publish papers. How do we get at that type of knowledge? And this is what Ahliauniversitybh was about. It was really about how do we gather data and prepare it so that multidisciplinary teams can do early economic evaluation. I'm not going to have time to talk through the headroom method, only to say that it's a simple cost-benefit analysis which looks at patient outcome and patient intervention. So we were using it for medical devices. If you had a medical device, is it going to be cost effective for you? The interesting thing about this project was that we had annotated data. So a lot of the research data we fetched in to this product and then started annotating it with, in that sort of middle, you get some sort of placeholder where you can see useful data. We used a set of tags. Here's just some example ones there. They get added to the research content with some of the references there as well. So this is about making our data available for carrying out some of this analytics. This data can be taken from existing data or generated by some of our analytical systems, ready to do some scenario analysis and economic modeling. We then took that data and then carried out some simulations on that data. So this project had two elements: the gathering of data, how do we store it in a semantically reusable form, and then some simulation models where I can pull the data into my model and use it and start carrying out some scenarios for my hospital in 5 or 10 years' time. I'll go through this one quite quickly again. So that is a research, my previous example was a research project which got commercialized. So it got turned into an entity that we can use more widely. This is a different one. This is a health case study where we got some government funding to work with a health system to help the health system improve. And this is more in line with the talk's title, in that this is about strategic testing, or it's more about strategic testing. So here we were looking at our A&E departments in West London, so probably about 4 million people, and they were looking at how to reduce unplanned attendances in hospitals and also reduce readmissions. So unplanned attendances, that's the ambulance type or people coming into accident units. How do we reduce that? And then also, once they've left the hospital, we don't want them to come back within, I think it's a 30-day period, because they're good measures of different parts of effectiveness in the system. You know, you've got two drivers for that. You don't want highly expensive accident and emergency beds used. You want people to leave hospitals and not have to come back, and you want some optimization at the front. We put a methodology and a team together, and I won't go through all of this, only to say that this was really our high-level diagram for bringing 4 organizations together and carving out the pieces that different teams will do. So we may have a requirement where we've got a company, WSP, doing requirement 2, Simulate, a big simulation company, producing another element of that. I won't go through that. So, our simulation approach. I talked a little bit about personas. We did a lot of demographic projections and really working out what is the population going to look like in West London over the next, here's some examples up till 2022. We also did it through to 2030 and beyond, but this was an area they were particularly interested in. What we overlaid in our system dynamics models here was not just the growth in people in the area, but also the growth in the health system as well. So there are some strategic choices that were made by the health system a year, 2, 5 years ago. They're taking place and they're going to affect the system. So you don't want to test your new ideas on a system that's still changing. So you need to be able to use system dynamics to understand what this future is going to look like. I won't go through this one. We then decided we wanted to model a number of scenarios. So our stakeholders wanted to see these. So they wanted to see what would happen to the health system if the growth in numbers of people, changes in demand, and then the 4 and 5 is really if we change the system in quite an ambitious way. And this was moving some of the health system back to ambulances or first responders and just reconfiguring the health system. These were our system dynamics models, and this is where we were modeling the starting line. We wanted to work out, before we test out our different interventions, what is the world going to look like in 2022, 2025. So we need something that does that. And it produced lots of these system dynamic type diagrams. And these are really predominantly around patient groupings, the time it takes to flow through different parts of the system. I haven't really got time to go through all the detail. And then with this, so with our system dynamics models, at the time, this was about a year ago, we could take those and say, I want to look at the world in 2019. We also did later as well, so 2025 or whatever. Go and tell me what a day in the hospital will look like in that world. So we could take snapshots of our data. These were loaded into that previous Ahliauniversitybh type platform, so we have the data to then reuse. And then we loaded a discrete event model, which is a different type of simulation model. The system dynamics model is looking at how things, in this case, we're really showing the number of people flowing through the system over the next 20 years. The discrete event model allowed you to look at a hospital on a per minute basis, people flowing into that hospital. What's it going to look like, the strategic change in this future world that we're planning? So we took the data, and I'll go through the summaries. Just before I go through the summaries, a lot of work with discrete event modeling is just working out exactly what these distributions are like. I won't go through the detail, but from the data, we want to know what happens at the different stages in that particular model, the number of discharges per day, per week, and things like that, readmissions. So then we ended up with a more detailed model. In this model, we're looking at, again, the hospital at any point in time. We also have, it's probably not massively readable, but down at the bottom, some of the strategic changes. So we can play around with number of beds, number of interventions of a certain type, and some of these types of things. I'll flick through these quite quickly. So you can do lots of simulation runs, changing ambulances, changing care taking place in ambulances, and then we produced a dashboard. Well, Simulate produced the dashboard in this work package so that we could show back to the health system. The interesting thing, I'll summarize this. We don't need to read all the details, but a lot of the testing that we carried out, we thought, the hospital would already know, but they didn't. They were making some assumptions. They were initially planning to open GP surgeries, so your local doctor, 24/7. So you've got a capability any day to walk into GP surgeries. With our simulations, we could show that would have no benefit on A&E attendances. What the simulation showed, again, being able to project the future and then run a day in the hospital on that future day, was that certain interventions could work, like ambulatory care, moving care earlier into the system. And then also, we had some hints around how to improve the link between leaving hospital and where you go next. So if you go into care homes or some intermediate care going out. I've done a little bit about the results and oops. Okay. I've got lots of slides, but I know I've got 5 minutes and I want a little bit of time. If anybody's got any questions, I could go on for about another, well, at least an hour, but I won't. I don't know how many red cards would get at that point. But what I will do is, I think to tie into some of the opening talks, what I've tried to show is research, UK research at Brunel. You can see from these are real industrial problems. So they've come to the university and they wanted some help. To get our help, we need some funding. So we've had some research funding to do this. What I've also shown a little bit is that we've brought different partners in. You know, as academics, we can't do everything. You know, you need to fetch some skill sets, maybe from industry, maybe from other academic departments. The other thing, to talk a little bit about the sustainability of this research as well. As you're carrying out these pieces of research, we've then fed them back into our master's and PhD community. So we've got these data sets, we've got these interesting problems, and they've led on to a methodology for team working for one of our IS students who looked at, you know, if I did the project again, how would I do that project? Another student looked at using k-means and fuzzy c-means, a different type of analytical technique. So when I talked about personas, you may be a frail, older person. Fuzzy techniques means you could have memberships of different groupings, so they make the simulation model work a little bit differently. So our research has fed back into that research community, but it does take quite a bit of work. You know, this doesn't happen easily. You need, I think, if there's any advice I can give on this topic, is there isn't an obvious way of doing it, but you have to sort of understand your own academic strategy. What do you want to carry out, and how do you make those linkages over time? So if you're researching too many things, this would be very hard to do. You have to sort of follow a certain path. Not all people necessarily want to do that. I think I'm going to flick through this modeling collaboration because I think I don't think I've got time for it. So we've done lots of work on what are the methods we use, types of models, you know, how we model data in terms of personas, flows and things like that, and really how data's reused. I think the last bit I will just touch on is often data doesn't exist. So dealing with large or big data sets, difficulty one is getting it into a format we can use with some of our models. The second problem, when you're in the more of a real world environment, data doesn't necessarily exist. Data farming is quite a good use of simulation for this. So if you understand the system, so I want to know what a hospital looks like in 2025, that data doesn't exist, but I can build my simulation model and generate data for that day. Armed with data for these days, you can then start to think, what strategies do I need to put in place to meet those demands? We used it in healthcare. I borrowed data farming has come out of the US defense industry. So, you know, they're using it to work out scenarios for very different types of scenarios, but exactly the same technique fits the health system, you know, where we haven't got that data. Those unknown unknowns that we're trying to tease out. I think, just on a last slide, I can see the cards that have been picked up. Really just to say, I said at the start, machine learning is very much about looking back, building our models so that we can build these simulations and look forward. I think what I've also shown at the end is also in these simulations, they generate some of this data, and we can then feed it back into machine learning. So our futures, so this farm data of the future, we can then feed back into our machine learning and start the process again. So there's this bit I'm still looking at, and it's quite an interesting area to play around with data. But I think thank you very much. I think that's enough.